You were sitting in a small, beige-walled billing office at the skilled nursing facility where your mother has been doing physical therapy for the last 26 days. The fluorescent lights hum above your head. The administrator across the desk slides a single sheet of paper toward you, and her finger taps a number near the bottom of the page. $15,247 out of pocket, due in 30 days. You stare at it. You wait for it to make sense. It doesn't. You say, very slowly, the way a person speaks when they are about to either cry or scream, and they haven't decided which one yet. I think there's been a mistake. My mom is on Medicare. She was in the hospital for 4 days. Medicare is supposed to cover this. The administrator does not flinch. She has done this conversation hundreds of times. She has it down to a rhythm. She looks at you with the same compassion you'd get from a parking meter, and she says the 11 words that are about to detonate your family's savings. Your mother was never actually admitted. She was on observation status. Listen to me right now. I need you to hear this because if you are watching this video and your parent, your spouse, or you yourself have been to a hospital in the last 24 months, this is the most important 6 minutes of financial information you will ever consume. That sentence, "she was on observation status," is not a clerical detail. It is not a billing technicality. It is a federally sanctioned, hospital-administered, multi-billion-dollar trap that is currently strip-mining the retirement accounts of American seniors at a pace that should be the front page of every newspaper in this country, and the media is not covering it. Your financial advisor is not warning you about it. Your hospital case manager will not explain it to you in plain English while your mother is lying in that bed because the entire system depends on you not knowing. I am furious. I want to be honest with you about that before we go any further. I have spent the better part of 2 decades looking at the wreckage that this single billing code leaves behind, and in 2026, with skilled nursing facility rates climbing past $400 a day in some markets, the damage is no longer a slow bleed. It is a hemorrhage. Families are losing $20,000, $30,000, sometimes $60,000 in a single month because of a checkbox on an intake form that they were never shown, never explained, and never given the chance to dispute. So, let me set the scene one more time because I want you to feel exactly how this trap closes around a family. And if it has already happened to you, I want you to know before we go one more sentence that what I'm about to describe is not your fault. It was never your fault. Take a breath. Put the guilt down. We're going to walk through this together. It's a Sunday night. Your 81-year-old mother, let's call her Margaret, because she reminds me of every Margaret I have ever met. The kind of woman who insists on carrying her own groceries up 2 flights of stairs at 81, because that's how she's always done it. Margaret slips on the 2nd step coming down from her bedroom. She catches herself on the railing, but not before her right hip twists in a way that hips at 81 are not supposed to twist. You get the call at 9:47 p.m. You are in the car within 90 seconds. You meet your mother in the emergency room at a regional hospital you've driven past 1,000 times, but never been inside. You spend the next 6 hours in a plastic chair watching her get X-rays, CT scans, blood draws, an EKG, an IV drip, a saline bag, 2 doses of pain medication. A doctor comes in at 3 in the morning. He looks exhausted. He tells you that there's a small fracture in the femoral neck, but it's stable. They want to keep her for monitoring. He uses that exact phrase, for monitoring. He does not say the word admitted. He does not say the word inpatient. He does not say the word observation. He says, we're going to keep her for a few days to make sure she's stable and to start her on some physical therapy. You nod. Of course you nod. What else are you going to do at 3 in the morning when a doctor in scrubs is telling you your mother is going to be okay? She stays in that hospital bed for 4 days. She has her own room. She has nurses checking on her every 2 hours. She has a hospital identification bracelet on her wrist. She has hospital food on a hospital tray. She is, by every observable, sensory, common-sense measure that any normal human being on planet Earth would apply to the situation, a patient who has been admitted to a hospital. She has not been admitted to a hospital. On a billing code somewhere in the basement of that building, she is classified as an outpatient, receiving observation services. The hospital is billing Medicare under Part B, not Part A. And here is where the trap snaps shut, because on day 4, the doctor walks in, smiles warmly, and tells you Margaret is being discharged to a skilled nursing facility. A rehab is what he calls it, because rehab sounds friendly, and skilled nursing facility sounds like a place you go to die, where she will receive 3 weeks of intensive physical therapy to get her walking again. You sign the discharge papers. Of course you do. You are relieved, you are exhausted, you have not slept in a real bed in 4 days. The nurse hands you a clipboard with 7 pages of paperwork, and you sign each one without reading a single word, because you trust that the hospital, the doctors, the nurses, and Medicare itself have your mother's best interests at heart. That signature is the moment the vault door closes behind you. 26 days later, you are sitting in that beige billing office staring at $15,247. This should make you furious. It makes me furious. And before I go one syllable further, I need you to do something for me. If this story is hitting you in the chest right now, if you are recognizing your own family in this scenario, smash the like button on this video right now. I am not being cute. I am not being a YouTuber. I am asking you to do this because in 2026, the algorithmic suppression on senior healthcare content is real. And every single like is a crowbar that pries this information out from under the digital floorboards and gets it in front of one more family before they walk into that emergency room. Subscribe and turn on notifications. You will never have to navigate this rigged healthcare system alone again. That's a promise. Now, take a deep breath. I want you to actually do it. Inhale through your nose for 4 seconds. Hold it for 4. Exhale through your mouth for 6. Do it with me right now. Because here's what I need you to understand before we get into the legal and mathematical anatomy of this trap. If this has already happened to your family, or if you are watching this with your stomach in a knot because your father has a cardiology appointment next Tuesday, and you suddenly realize how exposed you are, none of this is your fault. None of it. When you are rushing your mother into an emergency room at 1 in the morning while she is white-knuckling the dashboard in pain, you are not auditing CMS billing codes. You are not reading the fine print on a Medicare outpatient observation notice. You are praying she's okay. You are calculating how fast you can get to the hospital. You are trying to remember the last time she took her blood pressure medication. The system knows this. The system is built on this. The system is engineered top to bottom to extract maximum revenue during the exact window when a human family is least equipped to push back. That is not an accident. That is not bad luck. That is design. But here's the part nobody tells you. You are not powerless, not even close. The same federal regulations that created this trap also created the keys to unlock it. There are specific words you can say, specific documents you can demand, specific signatures you can refuse to give, and specific appeals you can file that flip the entire equation. Most families never use them because they don't know they exist. After today, you will. So, pour yourself a cup of coffee, get a notepad, and stay with me. We're going to take this apart bolt by bolt. Let's start with the rule that sits at the absolute center of this entire mess, the Medicare Part A 3-day rule. Here is the rule stated as cleanly and as factually as I know how to state it. For Medicare Part A to cover a stay at a skilled nursing facility, the patient must have a medically necessary inpatient hospital stay of at least 3 consecutive days, not counting the day of discharge. That stay must be at a hospital. The patient must be formally admitted as an inpatient, and the transfer to the SNF must generally happen within 30 days of leaving the hospital. Read paragraph again, because every single word in it is a tripwire. Inpatient hospital stay of at least 3 consecutive days, not 4 days in a hospital bed, not 6 days under medical supervision, 3 days as a formally admitted inpatient. A patient who is sitting in a hospital bed for 4 days under observation status has had 0 qualifying inpatient days for the purposes of this rule. 0. The fact that she had an IV in her arm, a hospital bracelet on her wrist, a chart at the foot of her bed, and a doctor rounding on her twice a day is, from the cold mathematical perspective of Medicare Part A, completely irrelevant. Not counting the day of discharge, this is its own little nightmare. Even if your loved one is admitted as an inpatient, if they are admitted late in the evening of Monday, kept Tuesday, kept Wednesday, and discharged Thursday morning, that may only count as 3 inpatient days depending on midnight crossings. And some hospital coders will argue it's only 2. The day of discharge does not count toward the 3-day total. This is why families who think they squeaked in under the rule sometimes get the same horrifying bill anyway. Within 30 days. If for some reason there is a delay in getting your loved one into a SNF after the hospital stay, that window matters. Miss it, and even a qualifying inpatient stay no longer triggers SNF coverage. Now here's what I want you to understand about the difference between inpatient admission and observation status, because this is where the system gets genuinely Orwellian. Inpatient admission, in the eyes of Medicare, is a formal medical and administrative event. A physician writes an order, admit to inpatient. That order, that single line in the medical record, triggers Medicare Part A billing, triggers the 3-day clock for SNF eligibility, and triggers a different set of payment rates and audit standards for the hospital. Observation status is, in the eyes of Medicare, an outpatient service. It is billed under Medicare Part B. It exists, ostensibly, for patients whose conditions are not yet clear enough to determine whether they need to be admitted or sent home, and who need to be watched for a period of time, usually less than 48 hours, to make that call. That is the original purpose of observation status. It was supposed to be a brief diagnostic holding pattern. That is not what it has become. In modern American hospital administration, observation status has been weaponized into a defensive billing posture. Hospitals are terrified of Medicare recovery audit contractors, the so-called RACs, who audit inpatient admissions after the fact, and can claw back payments if they decide the admission wasn't medically necessary. Under the 2-midnight rule that CMS implemented back in 2013, an inpatient admission is generally considered appropriate if the admitting physician expects the patient to require care that crosses 2 midnights. But expects is a squishy standard, and a wrong guess can cost a hospital tens of thousands of dollars in clawed-back reimbursement. So, what do hospitals do? Many of them, especially in markets where RAC activity has been aggressive, default to observation status. They keep the patient in a hospital bed, they provide everything that looks and smells like inpatient care, and they bill it as outpatient observation. From the hospital's perspective, it is the safer billing classification. From the patient's perspective, it is a financial catastrophe waiting to detonate the moment that patient walks across the parking lot to a skilled nursing facility. This is the part that should make every single one of you watching genuinely angry. Hospitals have a financial incentive to classify your loved one in the exact way that causes you to lose Medicare coverage downstream. They are not doing it to hurt you, they are doing it to protect themselves from an audit. But the result for you is the same. Now, I want to do some real math with you, because I want you to feel the weight of this. Let's go back to Margaret. 21 days at a skilled nursing facility at, say, an average $2,026 private pay rate of $725 per day in her region. That is $15,225 before you add ancillary charges, therapy supplements, and any incidentals. Round it up to that $15,247 figure on the bill in front of you. If Margaret had been formally admitted as an inpatient on day 1 of her hospital stay, and that admission had carried her past the 3-day threshold, Medicare Part A would have covered 100% of the first 20 days of her SNF stay. Days 21 through 100 would have required a daily coinsurance in 2026 that's around $210 a day, give or take, depending on the year's final CMS adjustment. So, her out-of-pocket on a 21-day stay would have been approximately $210. Total, 1 day of coinsurance, $210 versus $15,247. The difference between those two numbers is $15,037. That is the price tag on a single billing code. That is what one word on one form, observation instead of inpatient, costs an American family in 2026. And I want you to multiply that by the number of seniors going through American emergency rooms every single day. The Office of Inspector General has been raising the alarm on this for over a decade, with reports going back to 2013 and 2016, specifically flagging that hundreds of thousands of Medicare beneficiaries each year have hospital stays that look like inpatient admissions, but are classified as observation, leaving them ineligible for SNF coverage they reasonably expected to receive. This is not a fringe issue. This is a systemic, federally documented, decade-old crisis that is silently bankrupting the most vulnerable people in our population. And until 2026, almost nobody outside of elder law attorneys and a handful of patient advocates was talking about it in plain English. I want to pause here for a second because I know what's happening in your head right now. You are doing the math on your own family. You are thinking about your father's pacemaker. You are thinking about your husband's diabetes. You are thinking about your own knees and the way the stairs in your house have started to feel longer than they used to. You are thinking, what do I do? What do I actually do? Right now, today. Take a breath. Put the panic down. I know dealing with Medicare billing codes while your parent is in a hospital bed feels incredibly overwhelming, and it generates a kind of anxiety that lives in your chest for weeks. You don't have to navigate this rigged system alone. That is exactly why I built a free tool to give you absolute clarity before the emergency happens, not after. Before you stress about another medical bill or worry about which document you should be demanding at the nurse's station, click the first link in the description below this video or go to retireeshieldreport.com. In about 60 seconds, you can take a free estate risk assessment. The system will generate a personalized estate risk snapshot, showing exactly where your family's wealth is most exposed, including the specific gaps in your Medicare and long-term care planning that this observation trap exploits. Stop guessing. Stop stressing. Get your free snapshot right now so we can start protecting your family before the ambulance comes, not after. All right, let's get into the strategy. The actual practical walk into the hospital and do this right now strategy. The first weapon in your arsenal is a federal form called the MOON, M-O-O-N. It stands for Medicare Outpatient Observation Notice. Federal law, specifically the Notice Act passed in 2015, requires that any hospital receiving Medicare funding must provide this written notice to any Medicare patient receiving observation services for more than 24 hours. The hospital is generally required to deliver this notice no later than 36 hours after observation services begin, or sooner if the patient is being discharged or transferred. The MOON form is a federally standardized document. It tells the patient in writing that they are being treated as an outpatient under observation, not as an inpatient. It explains that this status may affect what they pay during the hospital stay, and critically, that it may affect their eligibility for Medicare Part A coverage of any subsequent skilled nursing facility stay. The patient or their representative is required to sign acknowledging receipt. Here is what I want you to do with this information. If your loved one is in a hospital bed for more than 24 hours, you are going to ask out loud to the nurse, to the case manager, and to the attending physician, every single one of them, this exact question. Has my family member been formally admitted as an inpatient, or are they currently under observation status? You are going to ask it on day 1. You are going to ask it again on day 2. You are going to ask it again on day 3. You are going to write down the name of the person who answers, the date and time of the answer, and what they actually said. If the answer is observation status, you are going to ask for the MOON form immediately. If they have not given it to you within 36 hours of observation services beginning, that is a federal compliance issue, and you can escalate it through the hospital's patient advocate or the state quality improvement organization. Then you are going to do the most important thing. You are going to ask, calmly and firmly, to speak with the attending physician about converting the classification from observation to inpatient. This is not a confrontational ask. You are not accusing anyone of anything. You are simply advocating for the medically appropriate classification. Here is the script. Write this down, take a picture of it. Save this video to your library so you have it when you need it. Doctor, I appreciate everything you and your team are doing for my mother. I need to understand her admission status because it has significant implications for her post-hospital care. Given that she has been here for more than 2 midnights, and given that she is receiving active medical care that I understand meets the standard for inpatient admission under the 2 midnight rule, I would like to formally request that you reassess her status and consider an inpatient admission order. I want to make sure that if she needs skilled nursing rehabilitation after discharge, she has the Medicare Part A coverage she has paid into for her entire working life. Can we discuss what would need to be documented to support an inpatient admission? That is a script written in the language the hospital understands. It is calm. It is informed. It signals that you know what the 2 midnight rule is. It signals that you understand the link between admission status and SNF coverage. And it is a perfectly reasonable, federally legitimate request that any physician can entertain. Some hospitals will say yes, some will say no. If they say no, you have additional rights. As of a federal court ruling in the case generally known as Alexander v. Azar, later affirmed at the appellate level in 2022, Medicare beneficiaries who have been reclassified from inpatient to observation by hospital utilization review have the right to appeal that classification through Medicare's administrative process. This was a significant ruling because, for years, the position of the federal government was that there was no right to appeal observation status. That position no longer holds for the patients covered by the ruling. What this means in practice is that if the hospital flatly refuses to admit your loved one as an inpatient, and they end up needing SNF care that gets denied because of the observation classification, you have a documented federal pathway to appeal. It is not easy, it is not fast, but it exists. And the more documentation you have built up during the hospital stay, names, dates, conversations, copies of the MOON form, written requests for inpatient reclassification, the stronger that appeal will be. There is one more piece I want to put in your hands before we close, and it's the piece nobody talks about. Do not sign discharge paperwork transferring your loved one to a skilled nursing facility until you have in writing a confirmation of their admission status during the hospital stay. Ask the case manager point blank, was my mother classified as an inpatient for at least 3 consecutive days during this hospital stay? Yes or no, in writing, on hospital letterhead, please. If the answer is no, you have a decision to make before that discharge signature ever happens. You can request a longer hospital stay to push past the 3-day inpatient threshold if her condition genuinely warrants it. You can investigate whether a Medicare Advantage plan she may have has different SNF coverage rules. Many Advantage plans waive the 3-day requirement, which is a real and underused piece of information. You can explore whether she has supplemental long-term care insurance that would cover the SNF gap. You can investigate private pay rates at different facilities to find the most affordable option if SNF coverage truly will not apply. You can talk to her about going home with home health services instead, which are billed under a different Medicare structure that does not require the 3-day inpatient qualifier. Every one of those decisions is better than walking into a beige billing office 26 days from now and finding out with no preparation, no plan, and no backup that you owe $15,000 you do not have. And if you are watching this and you have a parent, a spouse, an aunt, an uncle, a neighbor, a friend who is over the age of 65, I need you to do one more thing for me. Send this video to one of them today. Not tomorrow, not next week, today. One 5-minute conversation right now, before the emergency, before the ambulance, before the fall in the kitchen, saves a family $75,000 later. I am not exaggerating that number. I have watched it happen. A single forwarded link, a single text message that says, "Watch this, Mom, please," is the difference between a stable retirement and a wiped-out savings account. In the comments, I want to hear from you. Tell me your story. Have you or your parents ever received a surprise medical bill after a hospital stay that you thought was fully covered? What did the bill say? What was the dollar amount? What did you do? The comment section under this video is going to become, over the next few weeks, the most useful real-world archive of observation status horror stories on the internet. And every single one of those stories teaches another family what to watch for. Your experience matters. Share it and subscribe. Turn the notification bell on because the next video I'm putting out is on the exact appeal process for fighting an observation classification denial after the fact. What forms to file, what timelines to meet, what evidence to gather. You do not want to miss it. Save this video to your library. Bookmark it. Put it in a folder on your phone called Hospital. This is your survival manual for the next time someone you love is in an emergency room and a tired doctor says the words, "We're going to keep her for a few days." Before I close this out, I want to bring it back to the place we started. You sitting in that beige billing office, staring at a number that does not feel real. If that is where you are right now, if that bill has already arrived, if the SNF has already sent the invoice, if the collections letter is already on your kitchen counter, I want you to know that there are still moves to make. There are still appeals to file. There are still patient advocacy organizations, state long-term care ombudsman programs, and elder law attorneys who specialize in exactly this fight. The bill is not the end of the conversation. It is the beginning of one. And if you have not gotten the bill yet, if you are watching this in the calm before the storm, if your parents are healthy today and you are doing what good adult children do, preparing, then go to retireshieldreport.com right now and download the 2026 Retiree Asset Protection Blueprint. It is the companion document to everything we talked about today. It walks you through the documents you need to have on file before the emergency, the questions you need to ask your parents before they cannot answer them, the legal protections you can put in place while everyone is still healthy and clear-headed. The blueprint is how you lock the vault before the thieves know the combination. Get it. Read it. Sit down with your family this Sunday and use it. The whole point of this work is to give you back the peace of mind the system tries to take. You are not alone in this. You are not crazy for feeling overwhelmed by it. You are not behind. You are exactly on time because you found this video, and now you know. The hospital lobby is quiet at 3 in the morning. The fluorescent lights still hum. The plastic chairs are still uncomfortable. But the next time you are sitting in one of them with someone you love in a bed down the hall, you will know what to ask. You will know what to demand. You will know what to refuse to sign. And the most devastating bureaucratic trap in the American healthcare system will close on someone else's family, not yours.